So good morning, everyone. As Chris mentioned, I'm Melissa Rochon, and I'm the Trust Lead for SSI Surveillance, Research and Innovation over at Guy's and St. Thomas's in London. Just quickly, a little bit about my background with surveillance. It's an area that I've been working in for almost 2 decades now, and really fortunate to be involved in national as well as international committees on SSI prevention, surgical wound healing, and as well using digital images in wound care, which you'll see within this talk I'll come on to a little bit. Chris mentioned, and I agree, I hope this next sort of hour or so will give you an opportunity just to step away from work and routine and give yourself a chance to think of other ideas or approaches you might want to bring back to your own setting. I think for me personally, when I go to any sort of conference or session, what I really like is to sort of take that time to maybe feel inspired to do things a little bit differently, because it's often the case that things might not directly apply with what the speaker is covering, but you can take a part of it and bring it back. So this session will cover ways to enhance patient outcomes across different health settings, and we'd like to include children and vulnerable population as well when we're considering surgical site infection surveillance practices both in hospital and non-hospital environments. So by way of background, what I'll do is I'll just look at a really quick distinction between audit and surveillance processes, and sort of bring in again quite quickly, light touch, different forms of surveillance programs before really drilling down into my own area of expertise, which is surgical site infection or SSI surveillance. And then we'll go through sort of key or fundamental principles for surveillance, and those will apply whether, whatever type of surveillance you're undertaking, not just for SSI. And then I will cover examples of how we've used surveillance as well as audit to look at into two outbreak scenarios. Before moving on to what I think is more the meat of this talk, is looking at the challenges around sort of the traditional surveillance approach. Maybe it's not quite modern or fit these days as we're all stepping over to digital. And so we want to look at some emerging evidence for image-based approaches when undertaking surveillance. And then again, just going back and maybe reflecting how you can look at potential improvements in your own area. So that's the whistle-stop tour of what's to come. And so I mentioned by way of background, we'd have a quick look at the difference between audit and surveillance, which I'm sure you're already familiar with. But briefly, audit examines compliance against an established standard, or often referred to as a gold standard. And it uses usually a binary outcome, and it's performed over a certain period of time or number of activities. And that's quite important, because the purpose of audit is not to sort of continuously undertake these audits without actually stopping, reflecting on what you're learning, and introducing a change that might improve compliance before re-auditing. So sometimes you see centers are, giving streams of hand hygiene data, but there isn't anything to sort of flag when a change has been made, whether that's to a process or practice or to a product, and then reporting again the findings. In contrast, surveillance collects and analyzes and interprets health data really around defined public health goals and priorities. And with surveillance, you can actually have that comparison over time, and that's against your own performance internally, but you're also able to benchmark against external organizations or national programs too. And typically, successful surveillance programs will include audit to provide information on evidence-based practice. And an example of this would be looking at care bundles to prevent SSI. So care bundles are interesting because I think it's around 35 to 55% of surgical site infections are believed to be preventable. And what you can do is you can implement things like checklists or individual practices, or you can bundle them together so that the the elements come and have a cumulative effect on reducing risk. And I think, mentioning between 35 and 55% are preventable. I've also heard colleagues refer to cases where all of the elements of the bundle weren't performed, and that was determined to be an instance of preventable SSI. So what they're saying is effectively, if you can't demonstrate compliance with best practice, you should refer to this SSI as likely to be a preventable instance, which I think is a really powerful way to look at your practice and whether or not, sometimes with surgeons, SSI can be a biological factor of the procedure, but really we need to take the view that we need to make sure we're undertaking the best we can for our patients to make sure we're reducing their risk. Audits are often performed manually, but for centers that have electronic systems now, like we have, it's possible to work with your information technology group to get your compliance automated. So this data is collected robustly over time, where you're looking to see if your patients had their MRSA screening or if their blood sugar control was, within range on the day of surgery, or whether they had, an interactive dressing applied. And then you can take that and provide an overall compliance. In this instance, we've got 2 hospitals here being reported, and one hospital is, 95.5% compliance for the month, and the other one is 96.7%. And that gives really, important assurance to patients, clinicians, as well as to commissioning bodies that you have that overview of what's happening within your center, which can be really powerful. When undertaking PIRs, for instance, you can also pull this data automatically, which is quite useful. So we're really fortunate for our audit program to have quite a robust IT system. If you don't have similar, you're looking at just doing a handful of patients, maybe 10, learning what you can, and then focusing on areas for improvement. And one way to, when I sort of glibly say, look at your data and then identify an area for improvement, is to use something like the Pareto chart or principle. And this uses an 80-20 rule. And what it suggests is that you might have compliance issues across all of your bundle elements, but there will be the vital few actually where your compliance is low, and that will be contributing to the biggest overall problem. So here you can see that actually unintended hypothermia, antibiotic prophylaxis being given outside of the 1 hour, and poorly controlled blood sugar were the areas that we should focus on, and that will make the biggest improvement overall. And I think that's a really useful way to look at your data. Again, you don't need, years worth of audit data. You can do these sort of exercises with just some snapshot audits. So that's just a bit about audit. Into surveillance. And again, you'll be familiar that there are different forms of surveillance, whether that's health protection or incidents and case management, and outbreak control that you might be involved in. You might be involved in mandatory enhanced surveillance of HCAI, or you might be looking at communicable and non-communicable disease surveillance. So again, some of the principles I'm going to cover, I hope, are broadly transferable to these other areas. But I did mention this focus of this session would be using SSI as an example or framework for learning about things like audit and surveillance. So SSIs, as you know, are a globally really important and form of HCAI. And SSIs increase the risk of prolonged antibiotic treatment, hospital and ITU stays, NHS visits, including emergency visits. They increase the risk of surgical reoperation, readmission, and are accountable for about a third of your surgical sepsis cases. And these are really costly too. And those costs will increase depending on the depth or severity of infection. And because SSI are an important driver for antimicrobial resistance, preventing SSI is part of a global priority to preserve those antibiotics for future generations. Um, SSI can affect the trust as an organization. You might have maybe 10,000 operations each year. And if you have that sort of volume, you can expect to be using, thousands of bed days and managing SSI. So that's reducing, the elective surgeries, the throughput. And for the patient, of course, they're associated with an impact on quality of life, pain and suffering, and can be really devastating for patients and their families. And they can result in litigation. I think there was a 5-year look back by NHS resolution and found that SSIs were associated with sort of a 35 million pounds worth of litigation. So for all of these reasons, it's really important to reduce the risk of SSIs. And to do that in England, we use the UKHSA classification and criteria. Just briefly, these are sort of three classifications. Your two are superficial and deep incisional, so the infection is confined to the wound. And then you have the organ or space, which refers to the more severe type of deeper tissue infection or abscess that can be identified on direct observation during reoperation or through non-invasive means like investigations. And these criteria for SSI, it's really important that they're used consistently so that we are able to compare, because remember, with surveillance, you want to have it to benchmark your own performance. So that consistency is really important over time as well. That's what we use in England, but just quickly to sort of touch on the UK scene, that there are some important differences in which surgical specialisms are considered mandatory or not mandatory. For instance, C-section is mandatory, but for the other nations, but not in England. There are differences in data collection. Data for surveillance is known to be quite labor intensive, quite, resource intensive. So there are versions like in Northern Ireland, which just looks at more collecting the information on brief surgical details and then the SSI component rather than collecting everything about the patient, which can be quite time consuming. And finally, there are differences in duration. So some nations are conducting surveillance up to 30 days or 90 if there is an implant in place, whereas England and Wales do extend for deep and organ or space up to a year if there is an implant in situ. But just on the implants, briefly, they're considered consistently across these different protocols for the nations. And so if you're looking at things like joint prosthesis, etc., they would be considered an implant. So there are sort of 6 domains or dimensions of data quality, and this applies to whatever type of surveillance you're doing, but it really is important to sort of follow this through, and this would be particularly relevant if your own service was being audited. So at my trust, we had the good luck. I don't know if that's the right way of phrasing it, but we were audited externally twice during my time with surveillance. And so we had Deloitte come in and we had the London Consortium, and that was at the request of our board. So we were reporting high rates, and the board wanted assurances that we were following the surveillance protocol appropriately. So what these external auditors come in and do is they look for examples of completeness. So you have to show that you're identifying all relevant cases or operations to be included in your surveillance protocol, and that also your data is complete. They also are looking for relevance or uniqueness of that data set so that you're, for example, not duplicating something that the fellow in the next office is also working away doing, that you're aware of where your data sits within the organization and that it is relevant and unique, that it is accurate. So back in the day when I first started, we used to use Excel sheets to calculate our rates. But I don't mean that we were using the formula. I mean that we were putting the numbers in and then using a handheld calculator to add up and sort of divide the math there. And I would do it. And then I would hand it to the matron who would recheck it with her calculator. And unsurprisingly, there were a lot of errors. Even if you're trying to have that double check, if you're doing something manually, it just is going to introduce a lot of errors. So it seems, ridiculous now looking back at it that this is how we were calculating things. But at the time, it was very disheartening because, of course, people would spot those errors and then they would start to question the reliability of the data. And it took quite a bit of time to develop a report using, appropriate tools like the formulas or what have you to sort of build that confidence back up in the data set. Your data needs to be valid. And I think with using something like the UKHSA protocol, we were able to demonstrate that we're using epidemiologically sound definitions. So this wasn't something that we had, somebody had kind of thought up themselves and wasn't really comparable elsewhere. We were using a sort of nationally recognized program, that the data is timely. Again, going back, we found, 10 plus years ago, you would be waiting for the national surveillance report to, come out 6 months after you'd submitted the quarter. And by that point, you'd missed a lot of, the important trends. So we moved over to reporting internally every month so that we had that timely identification of issues. And it was interesting because we had an outlier notification recently in our orthopedic cases in knee. And when I looked at the high outlier notification, the UKHSA uses the last 4 quarters that you've submitted. But if you haven't submitted continuously, they use, the data that you've had submitted over the last couple of years. And so actually with this high outlier notification, they were including data that was, in excess of 2-3 years old. And I think that this is something that when you're dealing with data, it's really a good idea to drill down and question what is it that we're looking at. Even if you get an external prompt like this is a high outlier notification, you still need to question, is it timely and relevant now? And then the consistency. And for us, this is really around what is and what is not considered an SSI. And so when we had these external auditors, what they wanted was evidence that we had confirmed an SSI according to the criteria by the surgeon and that we had submitted that SSI to the national program. And it was really lucky at the time because we were getting all our consultants to email our confirm or refute. And what struck me at the time was we wouldn't have been able to demonstrate that process unless we had those emails where we could show that the consultant had approved or agreed with the SSI. And that's important because sometimes you have a corridor conversation with a colleague and they say, no, it's not an SSI. And that trail is lost. Because what they also wanted evidence of is when we had queried and the surgeon had refuted, and we had to show them that we had not recorded an SSI. And so it was really lucky that we had made a practice that everything was going to have that audit trail of whether or not something was an SSI. And for me, although the external audits were nerve-wracking at the time, and you felt like you were under a microscope, which is maybe how people feel when we're performing surveillance on them. I learned so much. It was so valuable to have gone through that experience. So I mentioned that we were reporting high rates, and I'm sorry about the quality of this older graph, but you don't need to really read it. It's just more wherever there's the red writing, it's notification of high outlier status. And I mentioned high outlier status before, but it just means that you're within the 10th percentile nationally, like the highest rates nationally, or top 10% of rates nationally. Now, it doesn't mean that there is a problem, but rather it prompts you to look into whether there could be a concern. So you should, if you receive a high outlier notification, be looking at your infection prevention practices. You should be looking at your case mix, and you should be looking at your surveillance methodology. And I already commented about our data systems really being quite poor, like, paper, handwritten, using handheld calculators, and as a consequence, no buy-in of the data. So when I look at sort of how surveillance starts for colleagues, it really feels like the old adage is true. If you start to look, you'll find more. And then it becomes this concern over the data in the first instance, where the challenges for colleagues in surveillance is really arguing about the data rather than focusing on the patient safety element. And it takes sometimes, and years to actually get a system in place where the surgeons have confidence and they know that the data that's being reported is really robust, and you can tell that they rely on it because they're asking you for that data for their publications, and then you've cracked it. Um, we've learned a few things along the way, and I've mentioned a couple of these already. It's focusing very much on the patient safety, rather, try and get the data side sort of sorted as quickly as possible so that you can focus on really what matters, which is driving change to result in better care and experience for the patient. Ensure that you have an auditable process to demonstrate your data quality. This is, little things like putting a read receipt on your report when you send it out. Like the auditor said to me, how do you know that you've got buy-in for your reports, like when you send them? And we had this beautiful example of where we'd send, and all the surgeons had done the read receipts and the managers had, and it was really fantastic to be able to show that. But again, very hard one and did not happen overnight. Having a senior or executive lead is just a huge benefit. I think for me, looking at other colleagues' experiences and my own, I would say this is another thing that really helps is you have somebody senior who's going to oversee the committee. And we had, I think it was the clinical lead for risk, who took that sort of lead role in overseeing the committee to look at SSIs, and that buy-in sort of is driven that way. We did ask for senior clinicians, consultants, in fact, to confirm or refute. So we didn't use, SHOs or anybody. We went straight to the consultants, because actually it's their rate. I know we all talk about the team, but the surgeons told me at the time, that those numbers goes against my name on my appraisals. So I would like to respond to the queries. And it really increased the confidence in the process, because they knew that if we were reporting rates of 12%, let's say for the quarter, that we had everything in writing that said, yes, this was an SSI. And just making sure that you're using tools that help develop your program, that's making sure stakeholders are involved in activities, that you're not working in a silo, and that you're using different tools like run charts when you're reporting concerns or demonstrating impact. And I will show you an example as we go. So we started to report in ways that would build confidence in our system or service. So as a rule of thumb, we moved away from just providing rates without putting numerators, that is the number of SSIs, and denominators, and that is the number of operations. And that was for transparency. so that people could see, if rates were being influenced by lower operative activity. We stopped reporting SSIs by consultants. It was quite an antagonistic approach that we sort of inherited when I started. If you had a surgeon who was only doing, say, 2 valves a month and one of them got an SSI, that was a rate of 50%. And that just isn't realistic to report. So we sort of always put everyone's data together, and we applied internal and external benchmarks. So we had the UKHSA rate, but we also had our target. Just as an aside, the other thing is around exceptions. If you're reporting 0 SSI in the rate, like in September on the far right, but there are patients sitting on the ward readmitted with a VAC in September, it's really useful just to put, some line of context as an exclusion. For example, saying, in September, one patient was readmitted requiring VAC therapy, however, did not meet the criteria for SSI, so that people know that you're not missing things. And it makes it really easier for people who are working on the front line who may have a different experience of the rates than you're reporting. So I mentioned that I'd love to give some examples just on how we've used surveillance and audit in outbreak scenarios at our centers. So this is going back to a time at the Royal Brompton. I don't know if any of you in this session remember that the Royal Brompton was the first unit in the UK to be impacted by Candida auris, which is now, quite a common pathogen in terms of people's experience. But at the time, it was relatively unknown and quite frightening for everyone involved. And, full credit to the teams that worked tirelessly trying to find out what was going on. And it was, the people talk about outbreak fatigue. I mean, we had the CRS for about two plus years, and it was really hard. But at the same time, amongst all of this, pressure with the Candida auris outbreak, we found that we were having a problem with superficial sternal SSI. And I say they were superficial, and you can see from these images, you'd almost want to say this could be a stitch abscess, and we should be, just like not recording it. But they were infections that were requiring management and persisted after the stitch or suture was removed. So we started to try and figure out, and you can see for both of these examples that the sternal, the drain site stitches are still in. So these are infections that are happening, quite early on, because usually you'd have those sutures removed by day 7, day 10. And we did a lot of work trying to figure out what was going on. And when we did a deep dive, we couldn't find anything in terms of the patient risk factors. You remember when I talked about outbreaks to look at case mix. So, what risk factors do your patients have? We also looked at infection prevention practices, and we worked with the UKHSA or HPA at the time, trying to figure out, is this seasonal? Is this something that's linked to the temperatures or humidity in the theaters? Is this something to do with the fans that we're using on the wards? Like, we looked at absolutely everything. What we could see is that many of these were culture positive with either really low, like commensals, like staph epi, CNS. These would be usually considered commensals, possibly opportunistic pathogens if they're introduced to the wrong area or unhealthy tissue, or missing entirely. Now, with outbreaks, you never have everything is pointing in one direction. So you do see, some gram negatives too, but in the main, they were gram positive. So we really couldn't figure out what was happening. And then we thought about the timeline. And what we noticed was when this sort of increase in superficial sternal SSIs started was around the time that the advice changed from excluding new surgical wounds from Candida auris screening to screening them and screening them repeatedly. So you'd have a patient who'd had surgery with their dressing on day 0 taken down, day 1 taken down, day 2 taken down, just to swab the wound, which didn't appear infected, but just to do the screening for C. auris. And what we began to think is actually, are we kind of inoculating the patient's own normal skin flora or commensal bacteria just a little bit deeper where there would be suture material present. And you remember, sutures are considered a prosthetic. They're, kind of like an implant if you think about it. And it takes far fewer bacteria to cause a concern if there's a prosthetic present than if there is than without. So we started to think, yeah, maybe this mechanical disruption, the nurses are kind of rubbing or poking along the incision with the swab, trying to get something like with a bit of exudate, because we know swabbing a dry wound isn't really useful, but they were just, constantly manipulating these wounds. And it's important to say that none of these wounds were positive for Candida auris. So we weren't missing any, potential sources for this fungal concern. And so we said to them, please, unless there's evidence of infection, exclude surgical wounds from any type of screening regime. And what we were able to do is to show, using a control chart, that processes were largely fine until this change of practice that was introduced in December 2015, when we included surgical wounds in the screening regimes. Now, it takes longer usually to stop a practice than to start one. And we did find it took some time. Once the peak hit, we had to do mass training, and still people were including these sternal wounds in the screening. But we did eventually return to our baseline. And like I had mentioned, there was the implications for practice, which is very common sense, I think. The example of outbreak number 2, in fairness, it was at our other hospital site. It was over at Harefield, and Harefield had been receiving low outlier status or notification. That is, that we were in the lowest 10th percentile of SSIs nationally for quite some time, when all of a sudden we saw like a jump in SSI rates. And it wasn't just in 1 month, it kind of was like continuous, that we were having these problems. And they were all of these patients were having like culture positive results. And if you think, usually you have a proportion of swabs that come back with no growth. So it was quite unusual that they were all positive. And not only were they positive, but most were polymicrobial. So you're seeing this real mix of bugs, and a lot of them gram negative, which is again different to the first outbreak scenario. And we were seeing things that really you'd find in the environment a lot. And we were really, really confused over what could be going on. And again, apologies for the kind of blurred picture on the left, but you can see the presentation was kind of different as well. It was more diffuse. It wasn't like this localized infection that we had in the first outbreak. So we're trying to think, well, what's going on? So there was no commonality in terms of the teams or theaters, and there was a striking mix of bugs associated with this rise in infection. We chatted with our microbiologists, and what they felt was, given the variety of different pathogens and the steady stream of SSI, this was usually linked with a widespread process change, okay, rather than to a specific area. So something in a practice, a product, or a process will have changed for all of the patients. And the only thing we could think of is that there were non-slip patient issued slippers that were started in April 2019 rather. And patients were being encouraged to walk to theatre. Now, if you think about Harefield, what's really unique about it is patients come from the wards, but they have to walk through the main reception. And they also have to walk through the main corridor, which is again linked with an outside entrance. And when we looked at the footfall just in the first lobby area, not the second lobby area, we found that over a 30-minute audit, there was over 200 people walking through with a mix of trolleys, laundry, rubbish, etc. And this was in the spring, so there was, muddy boots, wet shoes, etc. coming through, leaves and the like. And what we were thinking is that potentially, as our patients were walking to theatre, it might be that these anti-slip socks were a potential source of dust and mixed bacteria. So you've got this really absorbent material. And that once you get onto the table, because our patients who were having surgery got onto the same table that went through to theatre, and that's where these socks were being taken off. And you're kind of manipulating those feet and the socks over the theatre bed, and that's increasing the risk of this dispersal of the mixed bacteria, and we know that bacteria don't just jump into the air. We need to have like dust or something, dirt, something similar, and manipulation to have this spread. So a really simple implication for practice. We asked patients to walk in their own slippers or to use a trolley. We felt that the soles on slippers are less absorbent than socks. They can be removed without hand contact, and so they can be kicked off at floor level. They don't need to go up on the theatre bed. And also with socks, they are tighter, and you have like the cells released on removal as well, the skin cells. And again, that's sort of a vehicle for bacteria too. So we don't know if we never did any testing, but when we made the change back to walk in slippers or use a trolley, we found that the outbreak stopped. So it is one of those things where we've tried to use a lot of audit, a lot of looking at things simply, just the bigger picture, stepping away, what's the change here? And sometimes, it's easy if you have SSI. So I say easy, it's never easy. But if it's, localized in one team, you have this really clear focus of where you can or who you can work with. Whereas when it's a bigger problem, sometimes you feel sort of lost. But because we had our data on the prevention bundles, we knew that our prevention practices were robust, and we knew our patient case mix hadn't changed. And I think that's one thing about patient case mix. Although hospitals, say, oh, but our patients are different, the patients that you receive over time are probably not all that different. So you can compare, your own benchmark. That we could look and see with audit, maybe where there were chances or changes. But you'll also notice too that in this session or in these outbreaks, we were able to use pictures of wounds to give us an idea of what the wound looked like. And I think in the first example where there was a bit of pus, the nurse said, pus coming out of the wound, but you didn't have a sense of where that was. Like, was it, at the top of the wound, maybe linked to a suture, or was it like more central as it appeared? And these pictures have been incredible to help drive efficiency in our surveillance program and really improve our identifications. And this is an example for me that really speaks out. So a patient was discharged from us, and the GP saw him 20 days post-surgery and asked the community nurses to redress the wound because it was exuding plus, plus, plus. Now, what's really interesting here for surveillance nurses, my job is to go and find out the date of detection. When did this infection start? And it looks like query infection, the GP is mentioning, but there are no signs of infection. This is the red is what the staff have documented. And I'm thinking this is very, very strange. It doesn't appear like there was any problem with the wound, really. But add a picture. And unfortunately, this is an example of a wound, sinus sort of sucking or tracking wound that's very serious, and it's a mediastinitis. And this wound was MRSA positive, and sadly the patient passed. And I think that this picture was taken on the first day, but not with the notes. And I just think it speaks volumes to what we can learn when we put a picture in with the context of what's being recorded. And there are some examples of how centers or researchers are looking at the learning from images or the appearance of the incision. Before images, we didn't have sort of that documented memory of wound presentation, but now we can put kind of themes or trends together. And what the colleagues in Bristol are suggesting that is that typically we talk about SSI risk in terms of prevention practices as well as meticulous surgical technique. Now, I'm not surgically trained, and so we don't tend to touch on the technical aspects. But the colleagues in Bristol are saying, actually, if you have wounds that are, for instance, they have some gaping, then that's, a risk for bacterial ingress or contamination. If you have, puckering or issues with the tension of the closure, that can affect the perfusion of the wound, the oxygen, the nutrients, and that can lead to poor healing, and that can lead to breakdown in SSI. And these are or lots of suture material or excess suture material, that's a nidus for bacteria. And you can see how the technique can start to lead to issues with SSI. Well, what does that look like in practice? Well, example number one is of a patient where the woman developed a SSI distally, and probably in the past we would have thought, oh, well, the surgical bra was too tight or something like that. But here you can see it could be that, the lower subcutaneous fatty tissue was sort of with the diathermy or heat source was sort of damaged at closure. So you had that scabbing, which we know that bacteria love, like perfect medium for them to do really well in. And they can also come along the side and gain access to deeper tissues too. Number two is an example of surgical staples, which are supposed to be placed equidistant to help the skin heal. Again, I'm not surgically trained, but what you can see is where the number two is, there's that drift where it's not equidistant. It's actually not going to support the wound area very well. And indeed, when those staples were removed, that is exactly where the wound opened up. Number three is an example of tissue handling. Number four, that puckering or pillowing that we mentioned. And number five, right at the top there, you can see there's a stitch not there and some length present. And that is, of course, where the infection developed. So wound care is a really common area of nursing practice. And I think that it's a great way of helping us to monitor healing, and it could have an exciting role in SSI surveillance. But it's really important that we are guided by professionally governing bodies on how we are maintaining patient safety and privacy, consent, and the like. But I'm going to use that sort of idea of digital images to talk a little bit about the growing importance now of post-discharge surveillance. So if we agree that surveillance data and information are necessary to drive quality improvement, which I think everyone in this course is sort of signed up to, and that most infections occur after the patient leaves hospital. So we know from UKHSA data that about 75% of the SSIs present after primary admission, and that this proportion is set to increase because of shortening hospital stays due to ERAS programs, day case surgery, and the like. Then it becomes clear that the post-discharge element is important. So if you're not performing the PDS component, then you may not be, or you may be missing those opportunities for QI and patient safety improvement. So we can start to look at, well, how could post-discharge surveillance be done differently? Because let's face it, patients aren't returning for in-person reviews anymore. And there's growing evidence, although very early on, that using image-based approaches or patient smartphones is a way that this could be done. And we have a really good, high-quality randomized control trial from the Edinburgh team by McLean et al. And we also have our real world experience at GSCT. And what's exciting about this is that traditionally there's been a gap in how to collect performance outcomes like SSI are collected and how the patient's clinical care pathway sort of a siloed from that. So can we look at post-discharge surveillance as a way to kind of combine patient care as well as surveillance data? And if we're going to do this, we need to make sure that we're taking into account patient acceptability, accessibility, and their needs and preferences. But equally as important, we need to be careful we don't overload the already busy staff. And to do that, we need to make sure we're reprofiling or rationalizing the workforce to support digital, or indeed start to lean into artificial intelligence. So we did some research in cardiac surgery across 9 cardiac centers to examine some of the barriers and facilitators for SSI surveillance. And we conducted semi-structured interviews with 16 staff and then used thematic analysis to examine the trends. And I'll give you a moment to read the quotes. And I think for me, this is what I mean by the need to modernize or start to, if the NHS is modernizing, surveillance probably needs to keep up in step. So we can start to look at things like patient smartphones or mHealth to help us. And there are over 7 billion mobile phones. This was back in sort of 2015. So, even taking into account those numbers, some of them might be because people have more than one mobile phone. This could be a great way to collect structured questionnaires, have wound images, and use staff to access integrated web systems to have a look. And the way this has been demonstrated in terms of evidence is from the McLean work that I mentioned and his colleagues. So they used smartphones after general surgery. And what they found is that patients were more likely to be diagnosed in the first 7 days if they had used a smartphone than routine care. That the community healthcare attendances were halved, and that was without increasing the hospital attendances. And I think there was no difference in the A&E presentation. So this might have been more for less acute wound concerns. But I can say in the smartphone group, the A&E presentations were probably more appropriate because those patients were more likely to be readmitted than the routine care group. And it was patient satisfaction was high. We've published our own experience of using secure pre-programmed texts or emails, sending to patients or their carers asking for wound images and information on healing. And what's really important is there's no need to download, register, or install an app. Patients really don't want to do that. They use text technology, which has been around for the last 40 years, very easy and doesn't use any of their data. And they can also initiate their own follow-up in between if they've noticed a change on their in their wound. And for us, our team responds to all images and we provide important reassurance, practical advice, or referrals. So we're actually taking a step forward to helping improve patient care directly, rather than doing a retrospective 30-day phone call where the patient reports they have an SSI, that's not going to help them. It might help future patients, but the horse, as I say, has bolted. And what does that look like in practice? Well, you can see here the example of patients' healing pathway. At the beginning, they've got their drain stitches in, and then you can see it's removed. But what's really interesting is where the patient's reporting, do you have any gaping or opening of the wound? And the answer is no. And here is an example for me of where the image can really show that you're improving your data accuracy by adding the photo, but also you can intervene and you can get that patient treated before that concern becomes worse. So that's really, really exciting. And there are now ICBs, or integrated care boards, such as in Buckinghamshire, where GPs who have never been paid for post-op care and are finding, increasing demands on their services, they're actually now not going to do post-op care. So this means that those patients will be coming back to hospital. So it really is going to start to drive solutions like this to help identify problems early and think about how to improve patient self-management if we're going to avoid overwhelming our ambulatory services in hospital. These figures are a little bit out of date, but we've had over 15,000 patients submit to ILA. We've had over 90,000 or 95,000 submissions. Our rate has been, for response rates, has been sustained over 85%, which is amazing. Often, people struggle to get to the 70% target for UKHSA patient PDQs. And patients have a lower risk of readmission, surgical revision, or outpatient attendances when we use this. And our patients are responded to in under an hour, which I really think helps drive those response rates, because patients know that there's a human who's answering the text messages. They're not that keen to engage with algorithms. The response rates are much lower in those cases. But make no bones about it, transformation is hard, and digital transformation is even harder. So realistically, it's very easy to say, and we're doing remote wound monitoring, but we have done a lot of work to get this up and running. It's a busy slide, but we had to go through finance, we had to go through a competitive tender process to work with ILA. We had to develop the platform so that it was fit for use with our patients. And this is ongoing work that we are still, continuing to drive improvements. For example, we want to make sure that there's support and access for all of our patients. And as part of that, we need to be looking at our data to find out where patients may be excluded. So when we looked in cardiac surgery, for example, we found there was no difference in response rates depending on the patient's age or physical or cognitive impairment, but women were less likely to submit, as were those from lower socioeconomic status. In C-section, when we looked, we found that ethnicity was a big driver for differences, that individuals from Black or mixed ethnic groups were 60% less likely to submit to the white counterparts. But it is important to mention that the numbers were relatively low, but it sort of speaks to how are you making sure your surveillance program is inclusive and equitable. So it's I don't have all the answers, but I can tell you that we are looking to work together to make sure that we are addressing any barriers and to overcome these. So I'm just going to finish off now with a little bit of our work using artificial intelligence to help serve our surveillance program. I used to be really excited when we had like 50 pictures coming in a week, and now we have 1,400 pictures coming in every week, and it's a new workload for our staff. So I'm delighted to be working on a study called Wisdom, is the sort of short name, and this is developing and evaluating artificial intelligence to help clinicians prioritize and review submissions. So if you are talking about having using images, you need to make sure that they are good quality images. So the first thing the algorithm does is it runs through, and if your picture is blurry, it asks the end user, whether that's a patient or clinician, to take another picture to improve the review. But if the patient submits a blurry image, we can enhance that image also. Then the algorithm needs to go through the incision, look for incisions, and this might be the main incision or any adjuncts like drain sites. And then it needs to look for wound closure materials, because obviously you don't want to miss if somebody still has clips in, 4 or 5 weeks after their surgery. Then you need to look for markers, like is there any localized redness, any unexpected tissue or the like. And then from end to end, it kind of goes through, identifies the area, identifies suture materials, and identifies any problems with the wound. And for us, we have finished our work package on developing and validating the AI. And that has been submitted for publication, which we're really excited about. And we're currently undertaking a feasibility study. This is a small randomized control trial at 2 centers in Newcastle and at Barts, where they're using the ILA system in their patient groups. And we're collecting data. Hopefully, we'll be done that by Christmas. And what we hope is that we will be able to improve the staff experience of using digital, will reduce the use of healthcare resources, it'll be more convenient for patients, and will reduce complications. So from this sort of last hour, my take-home messages for you would really be around those quality domains. When you're working on your surveillance data, no matter what kind of surveillance you're working in, completeness, relevance, accuracy, timeliness, consistency, and validity are so important. Senior stakeholder and focusing on the patient is really, really key. SSI outbreaks, as we know, are never fun. There's unlikely to be a single mechanism. But audit can really help build a layer of understanding and guide some really practical recommendations too. And then in terms of the direction of surgical site surveillance, I really hope we can be looking to a more proactive model, which is using images and prospectively collecting data rather than the retrospective look back. So thank you very much for listening. I'll finish there. And come back to this group.
Lovely. Thank you very much, Melissa. I always love the Red Sox story because I think it's a really good reminder of sometimes the unintended consequences of what has been implemented for the right reasons.
Yes, yeah. Agreed.
And we never always know what the outcomes are going to be when we start doing improvement methodology. And
this is it. And this is why balancing measures or those upstream impacts, those unintended outcomes, and they can be positive outcomes. You may introduce something and something else happens and you think, wow, that's fantastic. And you might not know them at the beginning of your quality project either. But what was really nice about the Red Sox was how open colleagues were to recognizing that that change, that large scale change, because sometimes people keep just going through and saying no. They were like, we can see actually there is evidence that those socks put stuff on beds, so we'll stop that now.
That was good, lovely, thank you. Does anybody have any questions for Melissa?
Sorry, Melissa, I haven't got any questions, but just to say that I thought that was really useful because I work at Liverpool Heart and Chest. I know you work with Julie, our tissue liability nurse.
Yeah.
And I do the surveillance for the SSI. So that a lot of that was really helpful. I'm going to take that back to our team.
Oh, fabulous. Please send my greetings as well.
I will do.
Thanks.
That's lovely, thank you. That's great. So no questions for Melissa then? No, I think that's because you always explain it really well, Melissa. So
and I went to my app, Chris. Thanks, everyone. Enjoy the next.
That's brilliant. Thank you, Melissa. That's
Thank
great.
you. See you again. Bye-bye.
Bye. Okay, so it's time to have a break now. If you'd like to have 15 minutes break and come back at about 20 to 11, just hand over to you now, Caroline, ready for this session on demonstrating value.
Great, thank you very much, and good morning to everybody. So you've already heard that I'm cold. I've got my cup of tea, so hopefully you also have something and you're cozy or cozier than myself, but anyway. And yeah, we're going to just touch on demonstrating value this morning. I do have my colleague Kate Swan joining as well, so if somebody could look out for her joining into the Zoom, I'm hoping that she will join at some point. She's going to do a bit of a session, but not till nearer the end, so she may choose to join a wee bit later. But just if we could look out for that. I will also share my slides just now. Feel free while I'm doing the presentation, if you want to turn your cameras off, it just can help expand the sort of sense that you're just focusing on the slides, then that's absolutely fine by me. But what I will ask is when we're doing the breakout rooms and such, like, you would put your cameras back on unless we know that about already you've got issues or ever about your cameras, just because it makes communicating in the groups easier. And better for everyone involved where possible. And if you've got any questions, then please feel free to raise your hand or just unmute. Actually, just shout, Caroline, I'd like to ask you something. I'm really relaxed. I don't mind you doing that. If I don't see your hand, that's the point as well. I might not always see it once I've got my presentation up. So please just do that. Or if you do add it into the chat, we'll come back to it after. So I will just start to try and share my slides. So yeah, this demonstrating value presentation, it will be myself, obviously, and my colleague Kate will join us. But this demonstrating value presentation is based on a presentation from a Karen Naya, who would usually deliver this session for us, an RCN associate consultant who delivers on the main demonstrating value masterclass that we have. And she does also very kindly usually do the demonstrating value session for us for the IPC program, but unfortunately Karen is not available at present, and therefore you've got me. So hopefully it's not too disappointing by having me. But I will take you through the slides. And so obviously the slides will be based on what Karen would usually discuss and talk about in her session. And we will have some group work session as well, so that you can have some conversation with one another throughout. And it is quite a long session. I think we've got till, together with Kate, we've got till about 12:45, I believe. So we will take another bit of a sort of 5-10 minute sort of refresh, I think, just to let us get our stand up out our seats and refresh ourselves throughout as well. So today, we ultimately are just going to look at the understanding those principles around demonstrating value and economic assessment, becoming familiar with some of the key language and some of the common approaches around demonstrating value, and start to introduce some practical frameworks so that you can understand and begin to think about how you might demonstrate value in your clinical areas. So whether you are attending this course as non-academic credits or attending this course with academic credits, hopefully this information you'll find really, really useful, because whether or not you're doing the academic credits, obviously there is a place for change, supporting change in the areas that you work. And if you are wanting to support change and think about improving practice, you will want to think about how you demonstrate the value of what it is that you hope to achieve, or that you're perhaps looking to introduce a new service in your clinical area. And again, you would want to think about and be able to demonstrate what value that service is anticipated to bring. So really important either way. Obviously, for those of you who are doing your academic credits, you do have to submit your assignment, and you will be wanting to think about and start to demonstrate how you are thinking about demonstrating value and using this presentation as a basis for your understanding around that, and then obviously going on and doing further reading as necessary. So defining value in healthcare. How do we define value in healthcare? Well, Dr. Sally Lewis within NHS from NHS Wales, and in her book, The Value-Based Healthcare, the Only Game in Town, defines it here as having a firm grasp of what value-based healthcare really means and how it can be applied will yield benefits for patients, staff, and the wider healthcare system. So often, if you ask a room of healthcare professionals what value-based healthcare means to them, you're kind of likely to receive a range of answers, perhaps some of those quite cynical, that it is just about further cost and containment, demand management, and cutting services to the bone. But this actually is quite a long way from the truth if we fully consider what value-based healthcare really means and take some serious steps to put it into practice. So originally defined by Professor Michael Porter at Harvard Business School, value is defined as a function of outcomes and costs. Therefore, to achieve high value, we must deliver the best possible outcomes in the most efficient way. Outcomes which matter from the perspective of the individual receiving healthcare and not provider process measures or targets. This encourages us to focus also on individual preferences for care and ensure that resources are allocated for maximum value. So on the face of it, working towards high value healthcare is clearly a no-brainer, and yet we seem to find it so difficult. So clicked the wrong button there. So previous attention has been given to reduce interventions of low clinical value in the system, whether that be in imaging, pathology testing, or procedures and prescribing, with pressure being brought to bear on clinicians to reduce that unwarranted variation in these areas. And all of that is obviously fair enough, and we do need to think about reducing variation and reducing waste particularly, but obviously it can also be a bit uninspiring if we don't also at the same time seek to increase high value activity in the system. So what does high value look like? Unsurprisingly, the best outcomes are achieved at lower cost when we place an emphasis on prevention, early diagnosis, and intervention, and complete involvement of patients in managing their care and their records. Yet we still tend to be restrained about investing upstream for better outcomes, feeling forced instead into investing in firefighting in secondary care. Another obstacle to overcome that we do not do routinely and systematically collect the correct information on outcomes and costing to assess value across the system and pathways of care. Neither are we yet fully capitalising on digital enablers to change the way in which people can access and communicate with their clinical teams, as well as participating in and directing their own care. So talking about it is not enough. We cannot talk about value unless we are also prepared to invest for value. Bringing clinicians closer to managers and allowing them to participate in resource allocation for value is a much better way to incentivize us all to define and reduce low value activity. Value is professionally aligned to an emerging global movement encompassing overdiagnosis, too much medicine, prudent healthcare, realistic medicine, less is more, and choosing wisely. Done properly, it is rooted in person-centered care. So really, whatever you call it, it's really the only game in town for a sustainable NHS and, in fact, health and social care as a whole. So Dr. Sally Lewis, as you can see here on the screen, is Assistant Medical Director of Value-Based Care at the Aneurin Bevan, I can't say that name very well, University Health Board in Wales. If you want to follow her, she is on Twitter at RS Lewis Sally. So just that may be of interest to you. So, defining value in healthcare. The notion of value in healthcare has largely been based on the work of Professor Robert Kaplan and Professor Michael Porter of Harvard Business School in the US. They define the value as the health outcomes achieved that matter to patients relative to the cost of achieving those outcomes. So obviously in the image you can see there, the outcomes are the full set of patient outcomes over the patient pathway. The costs are the total costs of resources used to care for a patient over the patient pathway. The triple value model, Professor Sir Muir Gray describes 3 dimensions of value. Personal value, which is thinking about improving the outcomes that matter to an individual for a given amount of resources used, not only by the health system, but also by the individual and their family, recognising that experience of care is a critical element. The technical value, optimising the use of resources to achieve the best possible outcomes for people being treated within a given pathway or process. And the population value, investing resources more wisely within a health system to optimise the outcomes for the population for which the health system is responsible. Another approach to the triple value model includes allocative value. So the NHS Right Care Programme often talks about triple value, 2 of the 3 being related to the population and 1 to the individual, and that is seen in the NHS England NHS Right Care document that is available online, which we can share the link if you wish. So allocative value is sort of that determined by how well the assets are distributed to different subgroups in the population. Between programmes, for example, between cancer and respiratory programmes, between systems in each programme, for example, between asthma and chronic obstructive pulmonary disease in the respiratory programme, or within a system, for example, being preventative, drug therapy, rehabilitation, and long-term care for those with COPD. The technical value determined by how well the allocated resources are used to achieve the valid outcomes for all the people in need within the population, and personalised value determined by how well an outcome relates to the values of each individual. So, what is it all about? The HM Treasury guidance that you can see obviously here on an example of on the screen here, there are some examples there. Obviously, we've got the links for England and Wales, Scotland and Northern Ireland for individuals as appropriate. And they talk about the rationale. So you're thinking about what you're appraising or what you're assessing when you're thinking about the rationale. They also talk about being clear about the costs, the resources, the inputs. So to help identify the costs involved in your service, they suggest considering a variety of categories, such as staff and people, training, materials or equipment, premises, expenses, and budget. And also thinking about sustainability considerations, for example, carbon footprint and other resource data. So what you are thinking about when you're thinking about demonstrating value, you're thinking about what are the direct and indirect resources involved. So for example, example is what is then the true economic cost of those two elements, and where do these fall? Do they fall internally and externally or externally, and who incurs the costs as well? And what costs are incurred at setup, and what are costs that would be considered running costs. Also, you would want to be thinking about where do you see the benefits? For example, who benefits? Is it patients? And can we be more specific when we think patients? Are we thinking broadly, or can you actually narrow that right down? Also, who else benefits? We've got benefits for staff, organisation, partners, wider system, the environment. Again, that will be dependent on what it is that you are looking at. But we also want to think, when you're thinking about benefits, and when are those benefits going to be seen? Are they short-term, medium, or long-term benefits? And you may have a combination of all. And what are the tangible and intangible benefits? So what are the planned, the unplanned, the positive, the negative? You're starting to think also, you should be starting to think about some of those unintended benefits as well, which can be difficult because it's making you and forcing you to think out and beyond your project, but that's also, or your change, or whatever it is that you're doing in the environment in which you work, when you're thinking about demonstrating value, but also would be wanting to think about the unintended consequences as well. And I've already mentioned sustainability, and obviously it really does matter. We've had the previous presentation on one of our earlier days around sustainability, where we started getting you to think about that as well. So again, taking that into consideration, starting to have some thought around environmental costs and impacts as well. And can benefits be attributed to the service, or what proportion of benefits can be explained by the service? So for example, what do we know for certain? Do we know for certain that it was the service and not some other factor that brought about the benefits? So again, that would involve you, when you're thinking about projects and thinking about change, and you're thinking about implementing improvements and such, like starting to try and tease out, is it actually the change that's made a difference, or the new service, or the new improvement that you've implemented, or might there have been something else happening there as well? And for both costs and benefits, it's not about looking at everything. You want to account for additionality, so that over and above what normally would have happened. So we're going to look at, give an example. I've got an example here to include, and it relates to the single use of plastic gloves. So as you can see here on the slide, this is just giving an example of the scale and costs from current practice, well, a January 23 example. You can see, obviously, gloves are one of the most common single-use plastic items in healthcare. And between February 2020 and 2021, 5.5 billion, sorry, I'll say that again because I didn't know, 5.5 billion gloves were used in the NHS and social care in England alone. And by making one change to reduce unnecessary glove use, we can help make healthcare more sustainable. And you can get more information specifically about the RCN Get Involved campaign around glove awareness on the RCN website. But here you can also see the example of West Berkshire Hospital inpatient unit. So specifically the inpatient unit, they used 340,000 gloves between October 2021 and 2022, which at a cost of between £3.50 and £4.50 per 100 single gloves as supplied by the government. That equates to a cost of 11,900, between 11,900 and 15,300. And using the cost of gloves supplied to the Trust's PPE department, the NHS spends between, what is that, millions? I think so. I'm not very good when the numbers get beyond 6. But you can see there's a lot of money, obviously. Now, that's not to say that obviously we're not advocating that we shouldn't be using gloves at all, but it's about using gloves appropriately, when appropriately, and obviously reducing waste. In this example was this was their project. This is what they wanted to think about. And then obviously that kind of early observations on the inpatient rehabilitation wards suggest that around 25% of glove use is clinically unnecessary and potentially unavoidable. So not knowing this individual personally, I can imagine that what they did was obviously they got the costs, they understood the costs. They also did probably a bit of observational work to look at instances where they could see that glove use was being used unnecessarily as well. I'm sure we've all seen examples of people wearing their aprons and gloves and going to in and out of areas that they should or shouldn't do, or they're wearing gloves when they're not undertaking activities that actually really require gloves as well. So this slide is really just, again, demonstrating some key areas of literature that pertained to that, around that example. Other examples here, the first one here by this Wilson Loveday in 2017, looking at the use of non-sterile gloves has been associated with a significant potential for cross-contamination and transmission of healthcare associated infections. And obviously this is because they're often used when they aren't needed, put on too early, taken off too late, or not changed at critical points. The second one here is obviously looking at the wearing of gloves for a long time can result in hands becoming wet and soggy, leading to increased skin irritation, and then looking at the impact of that around the contact dermatitis, and how then common that is among healthcare professionals, and how that has been linked to the overuse of gloves, as well as then that reduced and missed hand hygiene as well. And again, if you're thinking about costs and benefits and demonstrating value, in that example, you would want to be starting to think about sick days in relation to contact dermatitis potentially as well, because that obviously would be an impact, or could be an impact, of the fact that they have been wearing gloves inappropriately. Not always, but it could be. And then also thinking about the contact and communication through touch emphasises a patient's hospital experience. So this was a research by Wilson back et al. In 2017, and that was about how it was demonstrating how patients can often feel uncomfortable with inappropriate use of gloves for personal tasks. So again, thinking about that in this example, the individuals looking at reducing plastic glove use, also starting to think about the experience from the patient or the person, the service user that is receiving that care as well. And then the final one here, again, another example, Sharp 2021, about it being estimated that for every box of 100 single-use nitrate gloves, it has a carbon footprint equivalent to driving 20 miles. So to travel around the circumference of the world is about 24,901 miles. according to Sharp. So then thinking about that example from Berkshire Healthcare Foundation Trust, the carbon footprint for their yearly glove usage is the equivalent to travelling 8 times around the Earth. And then obviously the IPU example, nearly 3 times round the Earth. So it's a lot to think about, and then obviously that would then be starting them to think about their carbon footprint as well. So what are the implications, and starting to think about widening your lens, if you like, when you're thinking about demonstrating value. So the direct costs may not be enough. You want to be thinking who, what, and what other resources do you rely on to deliver? Who else contributes? What impact does your activity have on others' resources? Also taking account of those less quantifiable inputs, outputs, and outcomes, the sort of negative and unexpected outcomes, and thinking that short, medium, and longer term, thinking more broadly. And you must shore up your claims, obviously, with evidence. So don't just assume you can claim impact. You do need to build your case, and that, whether that is for the purposes of an assignment or whether that is for the purposes of securing finance support or support for a project from senior management within your area, you really need to demonstrate and build your case for it so that you can show that to those that need to have that information. Think broadly about the best kinds of evidence as well if you need to do that. And it's not about including everything, as we've said. It's a focus on your rationale, and from that additionality, so that the what's over and above what would normally have happened regarding both costs, resources, and outcomes. Sorry, slide's not moving on. So where do we begin? Want to think about, we just want to start thinking about a question here. To be successful at demonstrating value, where should we start? Do we start with the data or exploring relationships? So how can you best demonstrate the value? Thinking about asking yourself three areas to think about: who, so the relational, the what, the technical, and then how much, the pragmatic approach. And do not assume that there's one standard way of demonstrating economic value. There's dangers if we start sort of that generally accepted theory or practice, and do not predetermine the approach. So whilst you might have some theory in which what might be helpful or what might be the cost, you really want to make sure that you are supporting that with evidence, that you're looking at data, that you're looking at the costs, you're looking at the experience of individuals and not just making some assumptions. And always ask yourself, who are you trying to influence or convince, and what are they looking for? So that falls into that relational element. The value to whom and how can this be captured? And also, what approaches can your data support? So thinking about the technical, and how much time and resources can you devote? So think being pragmatic. So again, we might all want to change the world, but that's probably not a really pragmatic approach when we know that time is limited. We don't have all the time in the world to change the world, but we can make some small individual changes, or we can make small changes within our areas of work that will gradually, if we all make those going forward, they can make a big difference. So it's thinking about being pragmatic about what you can achieve, or you think you can achieve, and taking it from there. So starting with the relational, so you're starting with the relationships and starting with that stakeholder mapping. You want to start identifying your stakeholders and start thinking about who they are. So for your service or aspect of your service that you have in mind, identify all the stakeholders associated with it. So thinking about the direct, the indirect, the internal stakeholders, external stakeholders as well. Identify the ones that you're trying to influence with the results of your economic assessment, the ones with whom you think sort of represent sources of direct and indirect costs, and the ones whom you think experience direct and indirect benefits as well. So you're not only including those that you think need to know about the economic assessment, you're also thinking about the stakeholders who will benefit as well. So this is just an example here of a stakeholder matrix that could be helpful. And the image was originally taken from an Anne McMahon, on the originator of the RCN Demonstrating Value Programme. And it actually is still the most current document that Anne uses in her book, or her resource around the Making Economic Cases for Nursing Innovations, Horses for Courses, a guide to economic assessment in nursing. So yeah, as I've said, you want to identify the stakeholders with whom you're trying to influence with the results of whatever area that it is that you're trying to look at in your economic assessment. Do you have direct relationships with them, or would you need other people to help broker those relationships? Identify the stakeholders, as we've said, that represent those crucial sources of direct and indirect costs. And again, do you need to approach them for relevant data? Thinking about the stakeholders that you have direct and have direct and indirect beneficiary from your service or innovation, and do you already collect relevant data on the types of outcome experienced by these different stakeholders? If you do, fantastic. You obviously have a starting point to understand how they benefit, or do they benefit from it. If you don't, it's something that you would want to start to think about. Another approach, thinking about stakeholder analysis, is thinking about high influence and low stake. So the group that you want to keep informed about your projects or your pieces of work, and letting them know how things are going, but don't expect too much input back. And then thinking also those that are high influence and high stake. So these sort of top priority, this group should be fully engaged in the project. So consulting them, keeping them in the picture, asking for their input, and making sure that they are on board. And then also thinking around those low influence and low stake, keeping an eye on this group in case anyone from this group wants to become more involved, or perhaps moves into another of the categories. Otherwise, perhaps just letting them know how things are going from time to time. So yeah, just when you're thinking about obviously your stakeholder analysis, because you do need to, for those of you certainly that are submitting your assignment, you do have to submit a stakeholder analysis. So it's a vital part that has to go along with that. And obviously for anyone on the programme, whether or not you're submitting, then if and when you are undertaking projects or pieces of work within your area or whatever it is that you're doing, actually, it's really helpful to start thinking about getting that list together about who you need to keep informed, who would be identified as a stakeholder, and then start to put them into the categories around the kind of high influence, low stake, high influence, high stake, and also maybe those that, just need to be kept informed from time to time. Also thinking about the technical, so what do you know? Remember, as I've said, it's that sort of horses for courses. Remember that the data and the evidence can be qualitative or quantitative, and it can come from lots of sources. So it may come through your own existing data or partners' data, other data that you have access through, or through evidence published elsewhere as well. It could be that you're collecting new data. It might be that you need to collect new data. And then also another question that you would want to think about is, are you interested in comparing your innovation with something else? And if so, what does this something else look like? So is that comparing your organization or service prior to the innovation, or a similar service elsewhere, or even comparing it to doing nothing? What you might want to look at if you were introducing your innovation, how would it look if you did nothing? And compare that to what it could look like or does look like by doing something. And then obviously you can use this information to identify which approach you can consider. So here we have an example of a pathways to outcomes model that you will or could find helpful. And you might want to consider using this as a framework and a tool for understanding and demonstrating value. So the usefulness of the pathways to outcomes approach is thinking that identifying in the first instance what is put in. So for example, what staff, direct funds, premises, materials, training, travel, by whom, so the direct or the indirect, and by when, so the setup or ongoing running costs. Thinking about identifying the types of outputs produced and which of those outputs are key. Starting to think about your key partners, again, those key stakeholders, those affected by and or benefiting from the service, and the tangible and the intangible, quantifiable and non-quantifiable outcomes. Start to think about your outcomes as short, medium and long term, and which are positive or negative, or another way to say that might be what outcomes are intended or unintended as well. Start to establish and think about the attribution about what is your compelling story, linking your outcomes to your innovation. You want to be able to sell your innovation or your change ideas to others, and then use the pathways to outcomes model for economic assessments as well. And not about measuring everything, it's about measuring what is important. So who are you trying to convince, whose value? Prioritize parts of your model in terms of looking at costs and benefits. And other uses for your model could be obviously around service design, service review, generating consensus and clarity internally, generating consensus and clarity with external partners, and a general tool for communication. It can be a really helpful way to communicate your ideas. Another example that I have used in the past as well, that we actually don't have a slide here for, is some of you may have heard of the driver diagram, a framework as well, and that allows you to identify the aim in which that you are that you're aiming for with your service improvement or your innovation or whatever it is that you're trying to achieve. And then it starts to think about the primary drivers, the secondary drivers, if there are some, and then your change ideas, and you are effectively working through that framework, thinking about what influences or what will have an impact on the aim. So they're all very similar. I guess you have to find what's useful to you, and perhaps if you're already familiar with using certain frameworks, then obviously if it achieves the same outcome, then I would suggest you stick with what you know. If you don't already have frameworks, then it's worth having a think about what might work for you. Right. So the following slides are just are some case studies. These are case studies from previous participants on the RCN Demonstrating Value programme. And again, if you want to see these and more, you can have a look at the RCN Demonstrating Value programme webpage on the RCN, and that can take, there are more case studies there. So I'm just going to take you through these case studies now, in the sense of touching on the fact that how we've just talked about the inputs, thinking about direct, indirect. They've obviously detailed here some examples of direct inputs, as thinking about that one whole-time equivalent band 6 nurse. This is a clinical nurse specialist-led children's continence service. So they've talked about the direct costs of the clinical rooms that they need, the clinical supplies, the equipment, the office supplies and the equipment as well. They've included some of the indirect costs for this service that they're looking at, around travel costs, leaflets, non-medical prescribing. The service here, they've listed some of the activities and outputs in relation to this service, around investigations, follow-up and review, that kind of independent nurse prescribing, referrals. They're also very clear about the groups targeted for this intervention, and here it is children from 0 to 18 years who have been identified as to have a continence issue. And they've then also specifically stated the area in which they are looking at. So they're not looking at all the children perhaps in this whole trust. It's within that specific northern sector of the trust. Again, it's about narrowing down to that pragmatic approach of what you can work towards. And yes, we want to make a change and make improvements across lots of areas, but we need to start small and start somewhere. And then they've listed the summary of benefits as well. So thinking there, you can see examples of, they've started to think about short-term outcomes, medium-term and long-term. Some of the long-term examples there being the reduction in number of children with long-term continence issues, avoidance of unnecessary tests and investigations. And then for the healthcare system, again, they've given that breakdown there of comparison of costs for a child with the daytime wetting and such like, and they've given the examples there. Another example, or the follow-on, sorry, from this is still the comparison of costs for the same example. It's just a wee bit clearer here around the positioning around this children with daytime wetting. Obviously, they know and they actually have identified on the bottom of the slide what they classify as definition of daytime wetting as defined by the standardization document. So again, that's the other thing to think about. If you're talking about a specific piece of work, then it might mean that you need to make sure that you all have a clear definition of what it is that you're looking at. Because unfortunately, we think we can communicate we're going to do a project on, for example, let's do the reducing glove use, but then actually, is everyone very clear on exactly what it is that you're looking at, what it is that you're measuring, or if you're asking someone else to observe practice for you, as well as you need to be sure that they are actually making the same decisions as you when it comes to making those observations. And again, that's been about being very clear and explicit about what it is that you want individuals to look at or audit or whatever. And they've got the comparison here, obviously, compared to referring to the GP, the total costs at the bottom versus the referred to the children's continence nurse costs. So very clear and explicit about the potential costs of avoided. So in this one, it's actually demonstrating, rather than actually the costs saved, is about the potential costs avoided. So again, it depends on your approach of what it is that you are looking at. Another example here for the clinical nurse specialist HIV community inputs. They've said that there's no setup costs. They have the community HIV clinical nurse specialist. They've given the costs for that. The resources that they need is that one whole-time Band 8, a travel card, and these are some of the indirect and shared hot desk, at the specific place in which they work. So again, it just talks about the service. It's given that little bit of background, some of the activity delivery, and listing the activities, and then listing the summary of benefits as well, or projected benefits for individuals. As I say, these are just some examples to try and help you see that model and that framework in use, and how people have used it for their own improvements. Here's another example here, the nurse-led transcranial Doppler TCD service. Again, they've talked about the investment, the funding, so they've included a setup and a running cost here, and it looks like they're doing the nurse-led in comparison to consultant-led. So they're being very explicit about the different costs, the setup costs, and then the running and operational costs as well. They've listed the resources, thinking about staff, travel and supplies. And then again, that journey through the service, listing some of those activities within that. And then the summary of benefits. And they have then clearly defined here as well the benefits for the patients and families versus the benefits, or not versus, sorry, but also the benefits for the healthcare system as well. So again, things included there around that reduction of hospital admission and bed days, reduce the waiting times at GP surgeries. And again, that can then, they're demonstrating the efficiency savings made by having it as a nurse-led service compared with the consultant-led service. So, is that another slide? Sorry, yeah. Optimizing the use of bladder scanners is just another example here. Again, all very similar. You can see that they just are being very clear about their positions around costs, projections, the actual service itself, and the benefits. So what I would like us to do, if somebody could support me to please put everybody in breakout rooms.
Go on, jump in. Somebody tell us what you were chatting about.
So we were talking about outcomes.
Okay.
So we were looking at the what might be short-term and what might be medium-term outcomes, and looking at who that would impact, whether it's patient, staff, organisation. And that was really all we spoke about because we didn't have very long.
No, 5 minutes is not long. No, that's true. Yeah, great. Thank you. So did you come up with any decent sort of thoughts around, like, because it is hard sometimes when you're thinking about short, medium and long term to sort of, because sometimes you can get a wee bit like, well, is this a long term or is this a medium term? Is this a and actually sometimes it doesn't matter as long as you're thinking about it. And then it's only maybe partly as you start to do something that you start going, actually, this is probably going to be a bit more medium term than it was. My ideal was short term. But
I suppose it was around really being able to identify
yeah.
the types of benefits and the types of, like the cost implications. Just identifying really the types of benefits of outcomes and cost, and identifying that first before you start. I'm just talking dribble really.
No, not at all. Not at all.
I want someone else to talk now.
Yeah, fine. Somebody else join in, either from that group or another group. There was, how many groups was there, Chelsea? 3.
I can see Stacey's unmuted. So
yeah, there was 3.
Yeah.
You're there then. Yeah, we were group 3 actually, and we were talking about the gloves and the gloves off campaign and that element of finance in relation to the financial benefits that you can get from it, but also if it was a campaign that didn't necessarily have that finance that flowed with it, then that can be difficult in the current financial climate in relation to where we're all at and that financial deficit. The other thing that we talked about was the element of national guidance as well. So, I mean, certainly through COVID, the national guidance, obviously the big element was PPE, wasn't it? And we can't get enough of it and what have you. So that, I think, heightened members of staff's awareness that actually I should be wearing gloves, I should be wearing an apron and what have you. But we've never had that step down as such in relation to that. So I think, and I've worked with Public Health England and HSE in a former role, and I think they are quite poor at that element of communication. So they were just, I mean, we talked about a couple of other bits, but they were a couple of the bits that we did kind of mention.
Yeah, it's a really good point, because I think that is, we step up, and that goes for anything. Obviously, COVID is one of the most recent examples, and particularly obviously thinking about PPE, but we do often maybe have to step in, we have to take different actions, but we're not always very good at then stepping back or taking that time afterwards to really reflect, really see it as a project of, okay, we had to step up so quickly, everything moved so fast, but actually, where are we now? Where are we today? What is it that we're doing today? And how does that fit with, guidance? How does that fit with up-to-date literature, policies, etc.? Are we now extended beyond that, or is it okay to step back? And I think we're not always very good at that at all. And often that can be because we're very busy, and we often just you get into the run of it, and you're so busy head down trying to actually do the day job sometimes that's sometimes difficult to bring your head back up and think actually. And I think that's why doing something like a program like this gives a really focused opportunity to ideally just sit back a moment and actually take a bit of a view across your service or across one bit of your service. Because again, thinking about the pragmatic, thinking about any improvement, you want to start really small. You can't necessarily go in there and say, right, I'm going to change the practice within 10 wards. It's like, well, actually, let's try and change the practice in 1 and then we can start to look at where we can move that onto the next areas, or if wherever your service is. So yeah, great. Anyone else have any other thoughts with what they were chatting about? It's really helpful for me to hear, and for the rest of your group to then, as a broader group, to hear some of the conversations.
We discussed, we were chatting generally, but selling it to the stakeholders, especially when you come from a charity-based organisation, on the understanding that you might have to spend a little bit of money in the first instance to get a really positive outcome. But yeah, selling it to stakeholders for me, that's
it is a challenge, isn't it? Because and I think that's where doing those economic assessments and having that clearly, using those frameworks and those models to really try and help you actually does become the communication tool, or it can do, because you then have actually thought about, yes, I recognize there's this cost, a setup cost, but look at what the potential is, and that can be really helpful. I mean, it's still not necessarily easy. I'm not saying that, but it can be. Then you're using those as that tool of communication. I mean, I was saying this the other day, last week, I think, at an event. It was actually about preceptorship, so it wasn't specifically anything to do with an improvement project per se. But again, we were talking about how to use guidance and the NMC code, all of these things, actually not just as elements that we have to comply with, but as a mechanism and as a tool to aid conversation of, here's what the requirements are stipulating, and this is what I'm trying to achieve, and using that all together with economic assessments, the models, pathways to outcomes, you can clearly show that you've started to think about how all of that together could make a difference to their organization. And one thing, I mean, from doing improvement over the years, definitely that experiential data is something we sometimes don't take, because it's not always the easiest to obtain or demonstrate, but actually it is really valuable. And if anyone's going to move, sometimes it's the stories that move people. If it's finance, it's probably finance that'll move financial people, but it's almost trying to pick, and I suppose it's like that horses for courses. It's like trying to pick, who are you trying to speak to at that point, and what do they need to know? And then you might be going to someone else and you're actually saying, right, what's the key point this individual needs to, or these individuals need to know? And you're actually having all of that story there allows you to pull and take what elements are important to the group in which that you are trying to communicate.
Yeah.
So yeah, great. Anyone else just got anything else they would like to share before we move on? Silence. Okay, I'll take that as a no. But if you do want to add anything into the chat, then that please do that. So I'm just going to do a wee bit of a summary around so thinking about this, just that demonstrating it in value in 5 steps, and then we'll move on. So making your case, that's just what we were talking about there, that is really what you're trying to do when you're trying to demonstrate value. You're trying to build the intelligence, you're trying to build or pull on the evidence. That evidence could be and will be at some point sometimes literature. It could be the data in your organization, whether that be the quantitative data, the actual figures, the actual costs, or the number of individuals that could benefit or do benefit, but it is also, as I've said, that experiential, and that experience of those individuals who are using the service or benefiting from the services that's really going to be benefit from it. So thinking about your audience, first of all. So step one is very much thinking about that stakeholder matrix. Why are you writing it? Who do you want to influence? What do you want to showcase? What are your key messages? Then that looking at the positioning and the context, the what, the why, and the how. So thinking about what are you proposing to do, outline that very, very clearly. What is the aim? What are your goals and your objectives? Why this? Why now? Just, listing some things, even for your own sake, listing those ideas around the key context and the drivers that we've spoken about that are relevant to the improvement in which that you're thinking about doing, and then also that sort of wider policy developments, or is there been local need that's demonstrated that there's a need for this now, and the reasons why could be that obviously the demographic has changed. It could be a number of reasons why, but it's having that very clear in your head, why this, why now, and how does your proposal support the key policies or targets. That's then bringing in that guidance, bringing in that evidence as well, and then which of those are then a priority for your project as well. Thinking about the key features of your service that you would want to underline to the reader. So if you're trying to sell this to a stakeholder, then what do they really need to know about the service to understand it enough? But because you can't tell them everything, so what do they need to understand enough to get a sense of why this is important? And has there been any other significant changes around activities, changes in demand, or the level of need, complexities, vulnerabilities, etc., and whether there are any significant differences in services that are commonly out there. So it might be that you're aware of other services delivering in a different way than you are, and actually they may be having good success in that or not, and that's why you want to do that bit of comparison there as well. Step 3, thinking about the costs. So thinking about those inputs, the resources and the costs, the people, the training, the material, the premises, those expenses, travel, budget, environment. Remember to be robust and show true costs around obviously staff costs, even VAT, subscriptions, etc. Thinking about that sort of bottom-up approach, count the various components, the sessions, the time and the materials, and the top-down approach, that kind of breakdown using a similar or existing set of resources, the proportions and the scale as well. And remember to start with the relationships, not the data. And don't always, and remember as well, you don't always need new or your own data. Consider unit costs or comparisons or research from elsewhere. Certainly it's really useful sometimes to have those conversations early to think, actually, does this data already exist? And therefore I don't need to collect anything new myself. Additionality, what's over and above what's already been costed, sort of that meaningful, not just counting everything. Be transparent, so keeping a record and stating what your assumptions are, and then your sources of information as well. And then thinking about the benefits. That's not moved on to the next slide, sorry. The benefits of who, what and why. So who will benefit, the service, be clear about this, who it is, the service users, the clinical team, the carers, the acute and primary or community care, social care, the environment, and in what ways, what do you expect will change for these groups as a result of your intervention or your innovation or your project work, and is that in the short, medium or the long term? And why do you expect those benefits as well? What evidence have you got? What research, models, patient outcome data, etc. And then finally, step 5 is thinking about the learning. So what worked well? What could have been done differently? What will the change be sustained over time? What future plans do you have to embed this? Now, for those of you that are doing your service improvement plan for your academic credits, you might not get to the point of having actually done any kind of intervention to actually have done the learning of how it went, but you might want to sort of speak about the fact that you're thinking about that you would need to be thinking about what worked well and how that then would influence over time, that you are thinking about the fact that you do need to learn from your information that you gain by undertaking the intervention or whatever. So what I would like us to do, just let me look at, yeah, kind of perfect time, is to go back into the same breakout rooms that we've been in, or in fact, you don't need to go into breakout rooms, sorry, I'm talking rubbish. I want you to just take a few minutes, we'll maybe take 5 minutes again, just quietly yourselves to start thinking about your own project. Or if you're not doing a project specifically for the academic credits for here, thinking about the areas in which you work, and start to think about, is there something that you know and you're aware of that could be better in the areas in which you work, and actually thinking about, well, if I was to try and make an improvement here, what kind of direct costs might there be? For example, the inputs, what are some of the activities, the groups? Start thinking about some of your stakeholders. I mean, this is not going to be your final product. This is just really to get you to start thinking about some of the outcomes perhaps, and I'm only going to give you 5 minutes, so you're not going to get very far, but really just use this as a bit of independent time to think about your own project. Take some notes yourself. I'm not going to ask you to share it with me either, so please don't then panic that, oh, I've written like 2 things, or you might have written lots of things, but just even bullet points of starting to think about some of the outcomes, that the area of work that you're thinking about. It could be that you've not even quite decided what you're thinking about, so it might be using the 5 minutes to start thinking about, what am I actually going to consider doing, and even, as I say, those that are not doing the academic credits with us, that's absolutely fine. There's still things to think about in terms of taking back some of the learning, or back to your area. What are you going to take back, and how are you going to implement some of that in your practice? So I'll stop talking for 5 minutes, and we'll come back at 12:05, and we'll move on from there. Okay. I wasn't going to give you much time to really think much, but it was just to give you a sense of, you've heard a lot about this morning, obviously, before I've joined, and also the demonstrating value, starting to think about your own projects as well. Yeah, so just a couple of last slides from me, and then I'll hand over to Kate. So some just key resources here to highlight that obviously could be useful, or will be useful when you're thinking about demonstrating value. And obviously you'll get access to these slides and the recording from today, so you can revisit as needed. And then thinking there around unit costs, we talked about using unit costs as well. So again, just some useful links there that could be helpful to you. Okay, any questions, any thoughts at this stage before I hand over to Kate? If we want to put our cameras back on just now, that would be useful.
We do a little bit more, and when I do the leadership session on day 6 for you guys, about influencing. So these sessions all link together.
Yeah. Okay. Well, if there's no questions at the moment, Kate, I'll hand over to yourself. If you want to introduce yourself, Kate, please.
Hi, everyone. My name is Kate, or coming up as Catherine Swan. I'm one of the professional leads here for education, working alongside Caroline. I'm not sure, do they need a wee break before this session, or have they had a wee break just before Caroline's? It's only going to be, what, half an hour, 40 minutes max. What do you think, Chris?
Yeah, Chris.
I think 5 minutes to stretch their legs.
Well, we do a little 5.
If there's time, Catherine, I think that'd be good.
Take a 5-minute break and just come back with a pencil and pen. You'll need a pencil and pen, or not a pencil and pen, a pencil and a piece of paper. A wee bit of work to do. Don't be getting excited. And nothing too taxing, but grab yourself a cup of coffee or stretch, tea break, pee break, whatever, and come back. That would be super.
Brilliant, thank you.
I'm going to really follow on from Caroline's lecture and feed into Chris's day five, isn't it? Day 4 and 5, day 5 and 6, day 6. Get it right, where she talks a lot more about leadership and communication and how to go around leadership. So I'm going to talk about leadership in the sphere of influence. And this is really, the next half hour or so session is really looking at what your sphere of influence is, not what your organization's sphere of influence is. So this is very much a one-to-one, and to get you to really think about where your sphere of influence can help, and especially when we're looking at your projects. Some of you I know are doing service improvement plans, but other of you will be carrying out small projects and small things within your own organization. And I think in order to get these to be much more successful, I think you sort of have to start and think about what is your sphere of influence. Now, some of you may already have heard of it before, you may have done the exercises before, but it's you know, I often do it multiple times when I'm doing projects to see where I sit within that project. So it's something that you can do continuously, time and time again. So what
have slides up yet, Kate?
I'm just going to pull the slides up and share. Okay, so we are going to look at, as I said, leadership and the sphere of influence. And you probably think, well, what exactly does that mean? And really this, we're going to really just get you to start thinking about, of course, my page is not working. Here we go. There we go. So we're going to start off with just a little Slido to begin with. Just write it in the chat. What influences leadership? Collaboration. Yep. Experience. Empathy. Excellent. Yeah. Compassion. Clear communication. Leading by example. Yeah. Role model. Really very good answers. Availability. Very good. Trust, again, someone trust again. So you see the theme coming out there: compassionate leadership, communication, being available, trust, empathy, all of these things that Chris will discuss even further when she does more about leadership. Empathy again, listening skills, very important, and being open to hearing what others are saying, again, listening skills. Harps back to that compassionate leadership, doesn't it? Fabulous. Well done, guys. That's great. So when we're talking about influencing leadership, those are all the things that do help influence it. But we've got to think about how you influence leadership and how you yourself as a leader, how you influence others to lead, and especially when we're looking at projects or something that you want to bring into place. How do you get everybody on the same page, isn't it? That's what it is that you're looking at. So if we just look here, this little area here, and we're just really looking at leadership
in the ability to influence others. And you've shown us how to do that through your listening skills and everything. And it's really a common goal, isn't it? It's a common goal that we want to do and to influence others and to achieve that common goal. And this influence can be exerted in various ways, from direct commands, okay, so maybe something's been put out there, a policy that has to be changed, or indirect persuasion. So if you're a good manager, you might be able to find people who are probably not on side. Caroline talked about it, that change, that demonstrating that value for something that's changed, is how do you get them on side? And that's sometimes indirect persuasion is often listening skills. You talked about it all there. You're listening, being open, being on the same page, and that's really what it's about. And then we're going to look at the sphere of influence in this area. And this is when there's a sphere of influence in the area of a group of people over which a leader has power or control. And that's the way they've written that is that it's not that power and control, but it is that people listen. You listen to them and they listen to you. And together as a group, you have that power to move forward. But you and yourself also must need to have that power. So we're going to go to look at, gosh, my computer is jumping all over the place today. Sorry, guys. So we're going to look at the sphere of influence. And a lot of you may have already come across this. This might not be anything new, but I want to really look at this one specific sphere of influence resource. And this comes highly recommended as well. It's a highly effective people, and it's by Stephen Combray. We're looking at this resource. We talked about the sphere of influence, and this is Stephen Covey, and this is nothing new really, because the sphere of influence was introduced probably in the 1940s by a psychologist called Kurt Lewin, and he describes various social forces that really shape individual behavior and attitudes. And people are, we're often influenced by a range of things like family, friends, colleagues, wider social network, the organization, that organizational culture that we work in. And these can often have a very positive effect on our impacts, beliefs, and values, but they can also have a negative impact, as we know. So the sphere of influence idea really was popularized by Stephen over the last few years, and he wrote this book called The 7 Habits of Highly Effective People. And if you're needing a little bedside reading, this is the one for you. But what Covey distinguishes is between what we call proactive people and reactive people. And this will probably sit with you when you sit and listen and think about people that you work with, or colleagues or friends. And proactive people are those who focus on what they can do and can influence. So very much, what can I do? How am I going to help this? What do I need to do personally? Whereas reactive people, they really focus their energy on things beyond their control. So they can say, well, how's this going to work? I don't know about that. That's got nothing to do with me. You can hear it all coming in. So reactive people are really, they maintain that attitude of almost victimization and blame. That's the kind of reaction you get. So the model is really based on these two circles that you can see here. And the first one is the circle, when you look at it, is your circle of influence. When we look at this diagram here, we can clearly see the blue circles, and the model is based really around these two circles. And the first one of us is really the circle of concern. We talk about the circle of influence and the circle of concern. And this includes a whole range of things like the pandemic. We really didn't have any control over that. Global warming, the state of the economy, what clothes your kids want to wear. Maybe they want to wear designer wear, all these things, attitudes in society, and even within the organization you work with. And the action list will depend on the individual. But the important thing is to understand that there may be little that you can do about it. For instance, the pandemic, there is little you can do about it. And these are the things that are out with your influence. The second is the circle of influence is much smaller, and these are things that you can do something about. Something that you can actually focus your energy on and influence what's happening in it. And these are things of everyday life, and this is where your sphere of influence probably comes into when you're trying to organize your projects and that. And this will really helps to affect any changes that you need to be made. Next slide, please. So we've got to think, oh gosh, why is that going to see, we're having a bit of a day. So additional considerations are expanding your circle of influence. Covey's teaching also encourage individuals to expand their circle of influence through their personal growth and development. And interconnectedness as well. They talk about that while focusing on the circle of influence. It's important to recognize that other actions can indirectly affect your circle of concern. And when you think about today, Karen was talking about, being pragmatic, your stakeholder analysis, trying to get things done. These things can sometimes knock you a little bit or perhaps not affect your influence. And this is where you have to work through. And this is where your leadership skills also come in that Chris will talk about later on. So the sphere of, as I say, so that's really about the sphere of influence. Next slide, please, Caroline. So we have many factors that actually affect the sphere of influence, and often position and authority, as you know. So we've got to think about these things. Leaders, in organizations, sometimes you get good leaders, sometimes you get bad leaders. And I think that's very important. Someone who's a manager might not necessarily be a good leader. And we've all been in situations like that. But they often have a defined sphere of influence based on their position. So people in authority have a role to play. For example, I put in there a CEO typically has a wider sphere of influence than a department manager. So you've got to think about that. So they have a huge sphere, but that doesn't mean, so you look at the different levels of sphere from where your sphere is in the position that you're in. If you're relatively junior, you may feel that your sphere of influence isn't particularly big, whereas if you are senior or a manager, then you feel that your sphere of influence is much wider. And we go back to the answers that you give earlier, where people had mentioned you're a role model, you've been listening. But I think a lot of that has to do with experience and taking that through and being able to actually lead from the top, and lead as a role model. Personality and charisma has a lot to do with it. And we do know that leaders with strong personalities, charisma, interpersonal skills can often expand their sphere of influence beyond their formal authority. And we all know that. I'm sure there's someone you can think that, gosh, they would make a great leader. You will always find people that you work with are people that are really good. They're very sociable and they do all those things that you said earlier. And this is where their sphere of influence may be even wider than someone else's. Relationships and networks is another one that affects the sphere of influence. A leader's ability to build and maintain relationships with others. It's like you've been able to build and maintain when you're changing, when you're doing your project, you're able to run with that. That's very important. It can significantly impact the sphere of influence. So if you're not able to actually be able to have that relationship and maintain those relationships, then they break down. It's very difficult to maintain your sphere of influence. Strong connections can provide access to resources and support. Again, when you're looking at your demonstrating value and you're doing projects, whether it's on this course or whether it's something at work, it's very important that you access and get support from the right people. So these networks are very, very important. Organization cultures and values, we had mentioned this before. So the culture of organizations can influence a leader's sphere of influence, very much so. So we get caught in that organization or within our culture or our values, and it's sometimes, that's what influence our beliefs as well. So it does have, does affect your sphere of influence. And here I've said that if a leader's values align with the organizational culture, they're maybe more likely to gain support and influence. And I'll put that in there because I think you feel like you almost that you have to be able to think outside the box and look and take in everybody's viewpoint and move on. It's that proactive versus reactive, and that certainly does affect the sphere of influence. And there's always external factors that we can't really get away from, such as, you know, the economic condition. You know, look what we are, the economic condition of the UK today, industrial trends, political events. I mean, we've had numerous elections here in the last few years and changes of, you know, who's the MPs and etc. And all of these can affect leaders' sphere of influence as well, because you can only, you know, if you have a bad budget of that, you have little to, and we talk about demonstrating value. If you don't have the budget, then it limits your sphere of influence. Next one. So this is a little project I was going to get you to do. So we've just sort of given you just a little bit of an overview there, but I really want you to think about the sphere of influence. So I just want you to take some time, just sort of clear your head a minute, all of you. I know you have a wee cup of tea there, hopefully. And we're just going to give you 5-10 minutes to think about this. So just on that blank piece of paper that I asked you, I want you just to draw 2 circles. That's basically all. And, you know, write just two circles inside each other on the paper. And what I want you to do is just really take a moment to think, maybe things that are contribution to worries or feelings or something that's overwhelming you. It might be something at home, something at work, something outside with friends, but just something that you feel is a little bit overwhelming at the moment, or anything at all that you can think of. Yeah. And then I want you to write that down on this, that worry item on your sphere of influence. Just write it on the top there and just think about what it is. Could be 1 or 2 words or a little sentence. And now I want you to think about it and think, you know, do I have complete control? Is this within my control? You know, is it something that, you know, I can deal with myself? I don't need outside help. Actually, I can resolve this. Okay. So you're trying to think, can I influence outcome? Right. So is it, or you think to yourself, well, actually, it's in my partial control, really. It is worrying me, you know, but can I partly resolve this item or influence the outcome through my own actions and behaviors? And you write this in the second circle. I can influence. And finally, I want you to think of something that is, with regards to this, it's completely out of your control. Okay, this is something that you really don't have any impact on at all. It's something that, you know, it's influenced by others that you have no control over. And write that on the outside of the circle. I'll just give you a few minutes on that. So what's within my control in the central circle, something that's worrying you perhaps, something that you know that you can actually deal with yourself. The blue circle, it is something that you can influence, but I might not be able to do it completely myself, but I do have a significant amount of influence on it. And then everything else goes out around the circle because you really don't have any influence at all. So an example to me to that would be like, you know, the climate at the moment. We have that big hurricane coming into America and they have absolutely no control of it. So what they do have control, what would influence that control, etc. That's just off. So now that you've done that, I want you just to look at what you have on the page, and we're going to review this. So for that little thing, for each little point, that little point that's worrying you, the most important thing to do at this stage, and this could be anything, it can be related to anything, to a project, to anything, is that whatever it is right now, and if you can do it now, it is helpful, you need to put one small action against it and how you're going to resolve that. And you may find that when you're doing the project, you're doing projects at work, or you're having to do change, that there might be 2 or 3 of these things. But the more important thing is to action it. Because I think if you have actioned it right away, then it starts. It's that feeling of instantly feeling better to say, well, actually, do you know what? This is what I'm going to do. It takes that pressure and that stress off. So you've identified an action. Where I can influence but don't have complete, and when you have partial control, what you need to do is to think about that. This is the bit of the sphere of influence that you really have to think about. This is the bit where you have to, there might be many steps that you need to write down as how you can influence this. It may not happen today, it might be tomorrow or the next day or next week. Or there may be at this stage you think, well, actually, do you know, I need to speak to people, or I need to get such and such on board. And this is where, when we talked about the last slide, when you become networking. So how am I going to help? How can I influence this decision that's going to be made or change this outcome? And the important thing there is really to not try to get everything resolved in one day. You've already made an action and you've done what you can. So now it's to think of the bigger picture. And then everything else that you've written out around the sphere of influence, you know, these are things that you're focusing on. They're out with your control. For instance, this hurricane coming in is going to affect your day-to-day work. It's going to knock down your house. What's within my sphere? Pack up and get the kids out of there, you know? But there's nothing you can do about that. So these things, there's no point stressing about these things. There's no control here. You can't control it. So everything else around that you've put out, strike it out, throw it in the bin and put it away, because that will heavily influence your ability to move, to do what you need to do within your control and help influence that control. So everything else. So when you think of it that way, I'm hoping that you'll be able to put this together with leadership as well. What is within my control, what I can influence, and everything else, it may be there, but you don't have any control over it. So you might as well strike it out and put it away and throw it in the bin or put it wherever, because you have absolutely no control over that. So what you have to get back to is what is within your control or within your influence. Now, this is hard because we often want to do everything, and it can be hard to actually strike through these things and say, okay, I just have to let that go because I have absolutely no influence over it. It's out with my control. And I think too, as nurses, especially, and maybe as women too, and men, we're trying hard to juggle, you know, this job and home and friends and everything, and you're trying to juggle it. So this is to try and clear out that bit that you really can't influence. You can't take it all on board, and you just have to really concentrate on what you can do. And if we go back to what Caroline was talking about this morning and your stakeholder analysis, this is where it can come into your stakeholder analysis as well if you're doing your project. You can look at what you want to do, which is within my control, and then you can look at who is the people we need to network, or how can I influence this? How do I get everybody on board? How do I get all the staff to, you know, tick that blue instead of green every day, whatever it is at your project? How do I get staff, you know, to wash their hands, you know, 5 times a day, or whatever that project is? So everything else, as I say, so you could also, you know, think about how that reduces the amount of activity that's going on. So if you've taken all of that outside influence, that's really, then it makes you concentrate exactly on what it is that you're doing.
Just conscious of time, Kate.
Yeah, I'm just going to think
it. Might not be able to do very long.
So we were going to do a wee breakout room to chat about this, but we've run out of time. But I want you just really to think about that. And if you want to chat about it in one of your discussion groups, then do feel free. But I really want you to, you know, when you first do it, you think, oh gosh, what are they talking about? This is, you know, rubbish. But actually, when you physically sit down, when you have a project and you think, okay, what can I influence and what can I not influence? It is the best starting point for any project, for anything that you're doing. As I say, you know, when you look at what you're doing and say, right, because if you have that in your head and you've put it on paper, then you have something to work with for that networking to grow and to grow. But it doesn't mean to say that just because you've struck out all of those things that you can't influence. You can influence as time goes on, but the most important thing is to concentrate on what you can influence, what your concerns are, etc. But getting that all on paper. Next slide, Caroline. Something's happened. So the sphere of influence diagram, we're looking at this, and I'm sorry, because I see here it's come up as the circle of influence and it should be the circle of concern. So apologies for that. I don't know, I must have misprinted that. Apologies. The proactive focus, things you can control, you cannot control. You can't control the weather, other people's behaviors. We know that we've worked, you know, within your own organization, within work, with work, you know that you can't control how other people, and this is where you see the proactive and the reactive people. This is where you see it every day if you're trying to do something of change. And obviously there's global events, as I said, we can see what's been happening in the state of Florida. You can't control that. But the circle of influence is your own behavior. You can control your own behavior, your own thoughts and beliefs, your own habits and routines, and your relationships with others. And when Chris talks about leadership, you'll see where this influence all actually fits together quite nicely. So I would just say when you're doing this, just to concentrate what you can do, and from that you can build a much bigger influence, and then your influence will start to grow much bigger. So as I talked about, expanding your sphere of influence is really about developing your skills. And you've mentioned it all when I asked at the beginning, improving communication, problem solving, decision making abilities. And as you find you're doing a service improvement plan, your very first one especially, you learn and Chris will probably agree with this, you do learn very rapidly how to problem solve those decisions and making those decisions and say, no, this is what we're going to do. Building relationships comes on the back of that. You have to cultivate those strong relationships with colleagues right down from junior to senior, because they all enhance leaders' influence and will help your sphere of influence as well. And demonstrating results, and you saw talking about the demonstrating your value, there is your results. Achieving the positive outcome, that really is where your sphere of influence has really, you know, got to an A star, because you clearly demonstrate the results and it's worked. If the results haven't worked, it makes no difference. It means that you have demonstrated that it doesn't work as well. So it works both ways. It's credible and it's influenceable, and people will remember it. And then for your next project, that sphere of influence will grow even more. And adapting to change, I think that's the most important thing. Effectively adapting to changing circumstances, and being able to do that, and using your sphere of influence to be able to help people to adapt to that change. So whether you're introducing a new policy or whatever that has come into play. And by doing that, you're more likely to maintain their influence as well, if that makes sense. So if you have built up that network and you've shown and you're able to adapt, you're that role model that someone mentioned earlier, you've been listening. And again, they'll say, do you know what? That's really, really good. I'll remember that for next time. And inspiring others, again, the role modeling, leaders can inspire and motivate others and can create a stronger sense of loyalty and commitment. And when you use your sphere of influence as that leader, taking that role as a leadership and really improving things, and for people to see that things are being improved, that overall care is being improved, then that is inspiring for others. Again, we're hark back to that role modeling, don't we? So I think that's it. So next slide, please, because I'm conscious we're pushing for time. So as I said, the leadership and the sphere of influence day, I thought it was 5 and 6, but Chris says it's day 6. I believe her, she's the boss. And I really want you to think about your sphere of influence and how it can contribute to effective leadership. You are that red pencil. You are going to take your project and you are going to run with it, and they're going to come with you. Okay, next slide. I have to apologize for all
It's
this.
just Q&A, so
Q&A, and that's me. And I apologize for the technical hitch. This computer is still telling me on the corner here to please update. So I do apologize.
Thanks, Catherine. The leadership is day 5 as well as,
It is
or
day
session 5 as well as 6.
Session 5 and
It's
6.
just it's in
it's
in 6. I talk more about that then.
Yeah. So. But I think within the sphere of influence, it's in everything. It's not just in leadership; it's in everything. But if you can get it in, think of that little project yourselves. I mean, it's just something to think about. But what the important thing, I think, when you're looking at sphere of influence is to try and strike out and get the negativity of stuff that you simply cannot influence. Put it away and start where you can, and then bring in all those people who are going to help you achieve what it is that you want to do.
It's a really good point, actually, because I know that certainly from my experience in doing a lot of improvement work and work with others, often we get caught up out here, and actually we find it really hard to get started because but I can't do that. I mean, that's nothing to do with me. I can't control. Yes. And actually having this as an exercise, just with those little circles of here's what I'm trying to achieve, and then start plotting that on your little circles, you start to realize, well, actually, if that's out there, that's not where I'm going to start. This is where I can start, and then I can start to look to grow and grow out, and that little tiny circle that might be tiny initially actually starts to really grow. But I think that's exactly a really good point, because we tend to get stuck, or sometimes we get stuck out here. So even with everyday things, I'm thinking, actually, I'm going to start using that for something else that I've got in my mind at the moment.
Because things like that, I mean, it's an automatic response, isn't it, Chris? We automatically go to with the bigger picture, and you think, forget about the bigger picture. Let's get back down to this little area that I can influence.
Yeah. So, I think it's helpful to help people to narrow down their project.
Narrow it right down.
Narrow it right down into what other bits that you can effectively work on. It doesn't mean you ignore all the other bits around the outside.
No.
For the improvement, it's just at this point in time, like I said, this is what I'm going to focus on for my project now.
Yeah.
Has anybody got any questions for Catherine? Or any comments?
When you're doing your the stakeholder analysis, if you look at that sphere of influence alongside, I think, the stakeholder analysis, it shows what you can go ahead and do and sort out yourself. But then it also shows you, okay, those stakeholders, they need to be, I need I need them in the outer ring of my sphere of influence, because they're the ones that's going to get me to where I want to be.